So I just wanted to give an introduction for our speaker today. So Dr. Shari Bolen is a professor of medicine at Case Western Reserve University, the founding director for the Metro Health Population Health Research Institute, the director of the Case Western Reserve University Center for Healthcare Research and Policy, and a practicing general internist. Her research is focused on cardiovascular risk reduction, and she uses mixed methods, implementation science, and systematic reviews to better understand and improve cardiovascular health among primarily disadvantaged populations. Dr. Bolen has many, many accomplishments, but I want to give her as much time as possible, so I will turn it over to you, Dr. Bolen.
Let me unmute. Thank you, Mackenzie. Good afternoon, everyone. I'm going to talk a little bit today about collaboration to address cardiovascular health equity in particular, and delighted to be here with all of you. I do, just as a disclosure, I'll talk today a little bit about projects that were funded by Ohio Department of Medicaid, local foundations, CDC, and therefore, the views in this presentation are really solely my own and don't represent the views of the state of Ohio or any federal Medicaid programs, the CDC, or any other funder. And my objectives today in some of this talk are really to identify underlying factors to address cardiovascular health equity, discuss some of the positive deviance approach for improving health outcomes and reducing disparities, describe what we've used as a collective impact model for establishing collaboratives that are focused on cardiovascular health improvements and health equity, and increase awareness of hopefully for all of you, if you're thinking about research or even quality improvement science or implementation science, really thinking about ways to help increase awareness of the different collaboratives, both regionally and across the state, that could be learning labs for any activities that you may be doing, or collaborations. And so some of you may know I like humor. I think humor is important in medicine. And we're coming up on Thanksgiving. So I thought I would share this meme of how pumpkin pies are really made. So hopefully that at least made you smile. So one thing that I want folks to really think about is this question, and I'm going to come back to it at the end, but really, what is one thing you can do in collaboration? It's always easier to do things by yourself than in collaboration. So what can you do in collaboration to address cardiovascular health equity? And if you're not doing cardiovascular focused work, maybe just thinking about something you could do in collaboration to address health equity in whatever areas that you're focused in. And I like to show this picture because I like the water and I like being out on boats. But the real reason for this picture is that when you see a bunch of people rowing together in collaboration, you move really efficiently, and you can have you can get things done really quickly and efficiently. And if you have one person that's really rowing out of tune, or we're not aligned in the work that we're doing, then it's just going to be harder to see an impact. So that's why I put that picture up there. So a little bit of background. This is looking at cardiovascular disease mortality, and the darker states are the states that are have higher rates of heart attacks and strokes. And Ohio, unfortunately, is in the top quartile of states for these events. And we know that disparities exist with higher rates of heart attacks and strokes among specific subpopulations like LGBTQIA+ populations, Black and Hispanic populations, as well as thinking about geography in rural and urban settings. And as we think about the drivers of health, I know many of you are familiar with this kind of pie. But especially as we think about this for chronic diseases, I think there are some diseases where genetics play a much larger role in premature death. But for chronic diseases, this is usually sort of the pie for sort of what drives death and disability. So healthcare is about typically 10 to 20%. So improving high quality healthcare is really important. But of course, social and environmental factors as well as behavior contribute quite a bit to those drivers of health as well. And this was a study that was not done by me, but others at Cleveland Clinic and Metro Health, looking at the 5-year cardiovascular event risk in higher versus lower affluent neighborhoods after adjusting for those individual clinical risk factors. And so what they really found was that the neighborhood deprivation index, which was a measure of that, what structures are in place within a neighborhood, accounted for about 1/3 of that variation in cardiovascular disease events compared to 10%, which was those individual risks that we usually put into an equation, like age, sex, smoking status. And what you can see by this graph is that on the very right-hand side lower graph where it says lowest 10%, that's actually the most affluent neighborhoods. Those individual risk factors actually predict heart attack and stroke rates pretty well. And that's when they're using electronic health record data to look at that. Whereas if you look at the top corner where it says highest 10% or least affluent neighborhoods, actually those their cardiovascular risk is much higher than if you just did individual risks alone. They don't all those little circles don't line up on the line. In fact, they have higher risk than is predicted just by those individual risk factors. And so on a map, when you look at this pictorially or as a figure, which I like to do, I like to see maps, you can see that there's higher risk of heart attack and stroke in some of those Cleveland neighborhoods that have the darkest red color on the left. And then if you look on the right, if you adjust for that neighborhood differences and just what structures are available in neighborhoods, you actually lose a lot of that. And that really demonstrates that those neighborhood factors, after adjusting for individual factors, it's really those neighborhood pieces that are contributing to a lot of that risk. And I know many people know about this, but I do feel like it's important to mention that historic redlining really still impacts Cleveland's health, and that you see high crime, for higher lead levels, and cardiovascular risk, all in these red neighborhoods, which really stem from disinvestment in those neighborhoods. And you can see this was a quote that was used as they were determining what neighborhoods should get help and support in terms of whether banks would want to lend to people. And this is sort of the quote: "The current state of the neighborhood will maybe be stable for another 2 years, but then we're going to see continued encroachment of colored families, which is going to cause problems." And then again, I think many of you have seen these kinds of maps where we know that within a 15-minute drive, there's 10 years or more of life expectancy difference, really based a lot on those neighborhood factors. And the last sort of preparatory slides before I jump into cases are really just to have us all on the same page. We really, when we're thinking about equity work, you start with inequality, where someone has more chance of getting an apple, for instance, because the tree is bent over in a certain direction. When you think about equality, we're giving everybody the same tools to get those apples, but because the tree is bent, really only one group benefits from the same tools and assistance. And so when we're thinking about equity, I think a lot of people are thinking about how do we tailor care to individuals in healthcare? How do we tailor in the community setting? And that's really important. And that's what this is showing, right? That somebody on this side of the tree needs a higher ladder. But I think one of the things which is harder to do, but people are trying to tackle now, is this justice framework, really thinking about what structures can we remove or put in place to really even out the playing field so we don't need to provide extra assistance. And that's here demonstrated with providing those extra supports to make the tree straight in this instance, so that each person has the ability to get an apple with the same tools and opportunities. So I'm going to jump into a series of case studies of work we've done around collaboration in cardiovascular health. And I'm showing these as areas that we've grown over the past 10 to 15 years. So it's not that we're doing everything right in these case studies, but just where we were trying to move the needle and how this is working and then where we're headed. So just wanted to make that a caveat that it's not that I think what we're doing is perfect, but where we've been and where we're trying to head. So, and if there's questions, you feel free to put them in the chat along the way, and I will do my best to look at those if it's, and then of course we'll have some time at the end as well. So this is the first case study. It's called, we use the positive deviance approach and collaboration to improve blood pressure control in our region. And positive deviance is really based on that. If you haven't read The Power of Positive Deviance, actually, I would highly encourage you to read that book. And I get no royalties from that, just so you know. But I think it's a really wonderful book about that you can think about for other work that you do. It's really based on the observation that in every community, there are certain individuals or groups whose uncommon behaviors and strategies enable them to find better solutions to problems than their peers while having access to similar resources and facing similar or worse challenges. And you know, if you're used to looking at data, we always try and line up the data to make it fit exactly our theory. In this case, you know, the biostatistician wants to get rid of the outlier, and that's sort of what this comic is. But with positive deviance, we're really trying to say, what are those folks doing? How did they make improvements? How can we learn from them? And this was actually really, maybe I should say not initial use, but initially popularized more in 1990. And it really, Jerry Sternin, who is a professor of nutrition at Tufts and was the director of the Save the Children program, was asked by Vietnam to create a program for childhood malnutrition. And they had 6 months to demonstrate impact. They had, like many of us, limited funding resources and need for a sustainable program. And they went to a poor district, convened stakeholders, and asked for volunteers. They weighed all the kids, they categorized them by income, and then they looked at what they were doing and conducted focus groups to find out how did families with low income still have better nourished children? So what were they doing? So they found that almost all poor families with better nourished children were washing their kids' hands a lot to remove the risk of infection. They were collecting shrimp and crabs from rice paddies, which at the time was considered a little taboo. And so not every family was doing that. They were feeding greens from sweet potato tops, and they were feeding kids small amounts 4 to 6 times a day because the kids would fill up quickly because they were unable to keep a lot of food down at the same time. And then they instituted a program of action, right? It's not just knowing what to do, but how to do it. So they had parent volunteers that had neighbors come for 2 weeks, and they showed them how to collect and prepare food. They repeated that practice in other villages, and they reduced the malnutrition rate by 65 to 85% within 2 years. So we took some of that better positive deviance approach in the Regional Health Improvement Collaborative Better Health Partnership. And Better Health Partnership is really a regional health improvement collaborative that at the time was publicly reporting on quality of care metrics at the clinic level using electronic health record data from over 200 clinics in over 10 health systems in Northeast Ohio. And the quality metrics were nationally endorsed, locally vetted, and it facilitated a way to identify those high achievers or outliers with common goals and similar challenges. So the approach was really find the bright spots using the data, interview everyone, interview the bright spots and see what they did, disseminate that process, and then remeasure to see if others improved. And then we would have a replicable, easy to say, evidence-based best practice. So here, each row is a unique Better Health Partnership member clinic, and all of these blue clinics were actually from one health system, and they had the highest achievement in blood pressure control. And they also, if you look at the blue rows here, they also had the greatest improvement in blood pressure control. So we went to them and said, what are you doing? And they ended up, Kaiser nationally published what they were doing. So I have that publication down here, but many of you are familiar with this who are in healthcare because we did so much implementation around it, but accurate blood pressure measurement, including repeating blood pressure if the first blood pressure was high, timely follow-up or monthly staff-led hypertension visits until blood pressure was controlled. They had a treatment algorithm that prioritized once daily low cost effective blood pressure medications. They had outreach to patients with elevated blood pressure using a hypertension registry and a communication curriculum that focused on building trust, addressing implicit bias, and health literacy. And these are the results that were seen when we implemented that at low performing practices in our region. We started out with about 68% of patients having good blood pressure control out of our around 150,000 or 120,000 patients that were part of this. And over a year, we really improved blood pressure control to 75% in the region. We almost completely eliminated the gap in blood pressure control by insurance type. So Medicaid and uninsured improved a lot. And again, we were focusing on those clinics that had worse blood pressure control, which happened to serve a higher number of Medicaid uninsured and minority populations. And we almost completely eliminated the gap between white and Hispanic populations in blood pressure control. And while we reduced the gap between Black and white populations, we did not eliminate that gap. And that's an area of continued focus. So before I move into our second case to sort of build off of that work, I thought I would ask you all a question. And I think, Mackenzie, we decided we're not doing this as a poll, so you're going to have to chat in your response. So what candy was invented in Ohio? Was it A, the chocolate kiss? Was it B, Lifesavers? So a little Ohio trivia. Or was it C, Tic Tacs? So I will give you all 20 seconds to guess which one it was. Oh my goodness, everybody knows Ohio trivia. It was Lifesavers. Look at all these folks. You know, does anybody know who it was that created Lifesavers for a bonus question? Well, people are knowing Lifesavers. That's good. Yeah. Well, so it was Clarence Crane. Oh, you know why? So Melody, do you want to text in or open why or open unmute and tell us why?
Isn't it because his son choked on a piece of candy, and so he developed a way so that if a kid was choking, they could still get air through the hole?
Oh, that's a really creative and interesting. I've not heard that, Melody. So my
Oh,
understanding, although maybe there's different reasons that that was created, I like that one. That's very life-saving.
I
Um,
thought that's why they called it
a
lifesavers.
lifesaver. The one, my understanding was that Clarence Crane he was a chocolate manufacturer and he was trying to create a candy that wouldn't melt in your hands in the summertime. And that and so he created a candy that was, you know, sort of in that shape of a lifesaver. And that's why they called it a lifesaver. But I kind of like your story, Mel. You know? So maybe I'll change it, or maybe there's two reasons behind lifesavers. So I do recognize that I'm showing candy and talking about cardiovascular disease, which is probably not the best approach, but now you know a little candy trivia for the state of Ohio. Oops, now let me see if I can go past it. So I thought that was a good example of how healthcare can try and work to improve high quality care and reduce disparities to some extent by focusing on clinics that are serving priority populations. However, there's a lot more, as I showed you earlier in some of those slides, as we think about equity work. And so I'll talk a little bit about spread here across the state as part of that case study too. So we really because of some of the work that we did in the region, there was a Medicaid had an RFA or an announcement out, and we applied for it to develop a statewide cardiovascular and diabetes collaborative called Cardio. And we really, for that, decided to use a collective impact model to establish that collaborative. And that's often been used in public health as we think about bringing people together to address a really complex and challenging problem. But again, here we were using it a little more on the healthcare side, but in collaboration and alignment. So the 5 key elements, if you're thinking about developing a cooperative around really challenging problems, this is a nice model to think about using and looking at, and really focuses on 5 key elements. One is a common agenda. So these might seem totally common sense to you, which hopefully that's how it seems when I frame them, but really having that shared vision and common understanding of the problem, The second is having shared measurement. So what are we focusing on and how can we have accountability to the work we're doing? The third is mutually reinforcing activities, really coordinating through a joint plan of action, and continuous communication, where we focus on building trust as well as a backbone support. And that may be more than one organization that supports staff and resources and skills to convene and coordinate different organizations, or it could be one backbone support organization. But often with collective impact, it's really usually more than one organization that's working together to try and do that backbone support. And this is so this is Cardio. We were founded in 2017. The mission of Cardio is currently to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population, links the 7 medical schools across the state, looking at identifying and producing and disseminating best practices to primary care teams, and using a number of different modalities for that. Monthly newsletters, an online repository of resources at cardio.org, podcasts that are available, webinars, and then a case-based learning model. We do an annual needs assessment of our members, and we have aligned quality improvement projects. And I always like pictures. So this is a picture of one of our first statewide conferences before COVID, and some of the certificates that people got for participating in our initial hypertension quality improvement project across the state. And I won't talk as much about the hypertension work here as the diabetes. Just again, as an example, we connected with the academic medical centers, Ohio primary care clinics, and the Medicaid managed care plans for this work. And this is the results, which again, this is a busy slide, but lower is better. We were looking at trying to improve the percent of patients who had elevated blood sugars. So we want less patients to have elevated blood sugars, and that's why lower is better. And actually, we started the project right during when COVID started. And so we actually worsened blood sugar control during COVID. And then I don't know that we didn't worsen it, but it worsened during COVID. And then we started to be able to develop processes during that time to try and do quality improvement with practices around reaching patients. And I won't go through all the strategies they use, but we were able to end up improving blood sugar control at the end of this project. The one piece that I wanted to mention as it relates to health equity here was that touching on that justice piece I mentioned earlier, or structures that provide barriers to individuals to get to have improved health. So this was one that Medicaid really worked with us and noticed that our patients really couldn't access a lot of services because of coverage. So Medicaid really began covering the diabetes self-management education and support program, as well as the diabetes prevention program, so that Medicaid enrollees could have access to these programs to improve their health. And then Medicaid also removed the prior authorization requirements for continuous glucose monitors. And so we then saw a lot of benefit to our patient populations who could then have access to that. And this is our current data on continuous glucose monitoring prescriptions. You can see that Medicaid in the blue line has the highest number of prescriptions for Medicaid enrollees because they were able to remove some of those barriers. I believe Medicare and commercial are now catching up to that. And we still have challenges with getting that for our uninsured or self-pay patients. So, so really thinking about where are there policy level barriers as we think about disparities in health equity work that we do. So that was one example of adding that in a statewide effort. So case study 3, I'm going to talk more about the social drivers of health, and now how do we start, it was great that we worked on these other areas, but how do we really incorporate thinking about addressing social drivers of health in communities to really improve health? And so that is really what this grant was our CDC Racial and Ethnic Approaches to Community Health, or REACH grant. And within that, the background for that was that really addressing social needs of safety net clinic patients we know could have a large impact on health. However, we didn't know a lot about effective ways to do that. And therefore we implemented a electronic health record facilitated clinic to community linkage program that would address those issues. So the project was really focused on enrolling 6 clinics at 4 health systems between 2018 and 2023. Patients at those clinics were referred if they were hypertensive adult patients at one of our clinics, adult patients with diabetes and elevated sugars at a second clinic. And then at 4 of our remaining clinics, they focused on children 2 to 17 years old with overweight, obesity, or with diagnosed asthma. And some of this related to what the health system's focus areas were and priorities were. And the other thing I'll mention here is that we worked with clinics that were serving priority populations in very specific neighborhoods that had the highest need or highest risk. The intervention was really in partnership with United Way 211. Many of you are familiar with them. They are a nonprofit organization that covers 2.5 million Ohioans. And they had a navigation specialist specific to this project who called referred patients to assess and connect them with any of over 20,000 community resources that they curate in their database. The 211 navigation specialist also called in follow-up to see whether patients used the resources and had any additional follow-up needs that needed to be addressed. And then they would provide electronic feedback to the clinics to say, what was done so that the clinical team could see what was being done for those individuals. And that was done through standardized health information exchange through the electronic health record. And when we looked at our referrals through March, we found that we had referred about 1,200 patients, and it really varied by clinic. Like some clinics only referred about 3% of the eligible patients, while others were referring around 43% of their eligible patients. And this varied based on capacity to do referrals and staffing and explaining the program. And it also related to just competing demands. At the higher clinics where we had greater patients referred, we were also using an electronic health record alert to let patients know that, or to let staff know that this is an eligible patient that could be referred. Whereas some clinics were not able to do that and were just running lists, which is much more manual and difficult. We reached 38% through the 211 navigation specialist. So they would get a referral and then they would reach out, and only 38% of those were reached. All of those reached had at least one need identified, and 87% had a need resolved or a resolution in progress. And I'll talk about what that means in a minute. We found that reached patients had an average of 3 social needs per patient, and they were connected with an average of 10 community resources per patient to address those needs. And this is just a look at what needs by adults and youth. So food insecurity it's probably not surprising to those of you who have looked at other things around social needs, but that's almost always is one of the top needs. In ours, we were trying to identify if they needed low cost or no cost opportunities for physical fitness. So that was one of our questions we asked, and that's why that's probably higher than you might have seen on other social needs screeners. But there was a large need for that. Housing and shelter, utilities are commonly seen, transportation. We were surprised that healthcare actually came up as a need because we were referring from healthcare clinics. But not everybody gets the educational resources they need within that healthcare visit. So a lot of those were healthcare education needs as well as mental health needs. And so in summary for that case, we really found that EHR facilitated closed loop clinic to community linkage program was feasible to identify and address patient social needs. However, we need really further research on what models work best to identify and address social needs. And I know there's a lot of work happening in this space now, and it'll be important in advancing health equity in some of that work as well. So that's sort of a summary for that work in the current space. And then I think before I move into the last example, case 4, I thought I would do one more trivia question, and you'll have to put another Ohio. I thought some of you might be sports fans. I know less about sports, but the Cleveland Guardians have a AAA minor league affiliate in Columbus with what nickname? Is it the Clippers, the Krakens, the Flippers, or the Divers? And so you'll have to chat in your response. We don't have a poll. I love it, Melody. Krakens. I like the question mark. But yeah. A couple people think it's the Clippers. Any other guesses? It should be the Krakens. We could rename them. It is the Clippers. I'm not even sure if Krakens is a name, but I did make that up because I thought it would be fun. So hopefully for those who are not sports fans, you now know a little bit. If you were and that was too easy for you, we'll have to come up with a harder one next time. So case 4 is really taking what we've learned now. We know that we can improve high quality care. We can link patients to community resources for health related social needs, although still a lot more to do there. We can work on areas of justice, but also when we're thinking about, heart health equity, still a lot of work to do, thinking about the neighborhood and how do we improve neighborhood, and community engagement in the work. So case 4 is still a little focused on the healthcare system, but more community engagement as part of the efforts. So this is a CDC funded grant that we just started about a year ago. And this is, I thought I would mention some of the newer work with the collective impact model as we think about equity. And it's something that, again, I'm not saying we're perfect in any of these, but I think is things that if you're having a collaborative or cooperative that's focused on equity, things you might want to be thinking about. So the first is really thinking about grounding the work in data and context and targeting solutions. So where are the disparities? Where do they exist? And how do we target to the right areas to have the greatest impact? The second is really focusing on systems change in addition to programs and services. And I think we've talked a little bit about that with policy level changes, but also systems changes might be regreening neighborhoods or greater investments in certain neighborhoods. The third is shifting power within the collaborative, and that can be really challenging to do, especially dependent on what funders want with the funding announcements that they set out. But I think really thinking strongly about that and how that works. The fourth is listening to and acting with community. And the fifth is really building equity leadership and accountability into the cooperative. So those are some things to just that they've added to the literature around collective impact, and that's based on collaboratives that have focused on equity and what's worked for them. And these are the 5 strategies that have come out of that work. And I have this link in the reference to that if anyone wants to dig deeper into that. So this is our Project Heart Health Equity in Cuyahoga County communities. And our purpose was really to improve high blood pressure. The purpose of the grant was to improve high blood pressure and cholesterol within identified neighborhoods at highest cardiovascular risk through these 3 strategies: tracking and monitoring clinical and social needs so that we can think about how we have align with others to have a greater impact. Within the primary care space, thinking about implementing team-based care, and in particular, how do we work with both community health workers and clinical pharmacists more in this effort. And then the third is around linking community and clinical services. And one thing about this map that I wanted to mention is this is looking at, we were required as part of this grant by CDC to focus on areas where the hypertension or high blood pressure prevalence was greater than or equal to 53%. And that's why you see these red neighborhoods here representing those 15 census tracts or very small neighborhoods. And you can see, well, I'll mention in a second the neighborhoods, but when we looked at this across the state, there were only 31 small neighborhoods or census tracts that met this criteria. And of those 31 neighborhoods, 15 of them are actually on the east side of Cleveland and Cuyahoga County. So we decided actually to focus our grant on our region because of that, because they're to have a greater focus and alignment and engagement within these neighborhoods. So you can see some of them are in the Huff neighborhood, some are Central Fairfax. We have some in Lee Miles neighborhood, in and around Garfield Heights and North Broadway, or Kinsman, that's probably closer to Kinsman. Up in North Collinwood, very close to South Collinwood, here in sort of Euclid area. And then also East Cleveland neighborhood here. So just wanted to, I know a lot of folks are actually doing work in a lot of these different neighborhoods. So part of this is also trying to align different efforts. And the Cuyahoga County Board of Health has a CDC grant where they're working on several things within the neighborhoods to improve the neighborhood conditions. So really trying to align with that work. So the main thing I'll share with you in this effort is we really explicitly set up a health equity and community engagement team as we thought about this work. We have a lot of partners, and this was actually our initial set of partners. We do have a growing set of partners that are working with us, because one of our goals was to increase the community partnerships for this grant. So you can see barbershops, you can see Cleveland Housing Network, and some of the community development corporations. So we're working on continuing to expand some of those partnerships over the course of the 5 years. And the other thing I'll point out, again, as we think about centering equity, is really having that steering committee that has health system leads, community partner leads, government partners, and payer partners to really help us think about the work together, and thinking about sharing power and leadership and what we do together. And we had a big co-design effort for 6 months of this project to co-design the work together as well. So I think just thinking about those ways of trying to engage more with everyone as we work together. We had, we're using existing community advisory boards as well. And then we actually set up a patient team based on feedback that came from our co-design. And those patient partners have been wonderful so far to interact with lived experience in those neighborhoods. So that was the last part of our case. And I had to, unfortunately, pick only limited cases to talk about, but I hope this increased some of your awareness of the different collaborative, cooperative work, which could be useful in any work that you're doing. And I really wanted us, with the last part, I know these science cafes are meant to be a bit interactive, right, Mackenzie? So part of this is to hear from all of you. And I thought I'd start out with just this question, but we can have any number of discussions or questions. But what's one thing that you or we can do in collaboration, you think, to address cardiovascular health equity, or just health equity in the work that you're doing? And I'd love for you to just chat in anything that you might be thinking of related to this, and then we can do some discussion and questions as well. I'll give you guys a minute. And actually, while you're chatting that in and thinking about that, I do want to acknowledge all of the many partners, because this work is collaborative, as well as if you are interested, there are additional publications that describe some of this work in more depth. And I also wanted to share one of my favorite collaborative quotes. So you may have heard this before if you know me, but this is by Malcolm X: "When I becomes we, even illness becomes wellness." So I will go back to the question here, but I thought while you guys are writing down your thoughts and or questions, I thought I'd show you that. And okay, so I will start looking at this, but I expect other people to put in chats as well, trying to answer this question, even if you haven't chatted it yet. So Tim, you were saying the map is striking, that the East Side certainly has socioeconomic status, social drivers of health, and poverty challenges, but why is the West Side spared? There is some poverty there as well. The East Side is the downwind from the steel yards, and this may deserve a more granular assessment. Great. And I don't know, Tim, if you were just talking about that last CDC grant, which is, you know, where, or if you were going back to the other map at the very beginning, where we were looking at redlining effects on Cleveland, that does have greater distribution than just the east side of Cleveland. And so I don't mean to say that there's lots of areas within Cleveland that need attention, not just the east side of Cleveland. For the CDC grant, it just happens to be that hypertension prevalence is higher in those particular neighborhoods, which is where that focus is. So I'm not sure if you wanted to unmute and say more, but I completely agree that we don't want to only focus on the east side of Cleveland in our work as a whole for Cleveland and health equity. And that was just one example of a project and how it's been funded. So Tim, I don't know if you wanted to say more about that.
Yeah, no, first off, I just wanted to say thanks, because I'm always, whenever I hear you talk, I'm so excited to see that positive stuff can happen if you take a little bit of a different approach, because a lot of this obviously can be frustrating. So thank you. And then this, I guess what I was getting at, which I kind of didn't say explicitly, is that we don't have super detailed air monitoring on the east side, but we would expect, just by where the east side is in relation to the steel yard industry, that pollution is headed that way. And that's where the predominant winds should take it. And so when I see that map with my environmental health background, I just think, oh, that's where that would look exactly like the air movement modeling maps. And that's probably not the case, but it might be a factor. So it makes me wonder.
Yeah, that's a great comment. And I think there is, and I'm not the expert on air pollution, but I know there are a lot of, there is some work happening in that space. One is related to work that Sanjay Rajagopalan's group is doing at UH in partnership with community partners and looking at the impacts there. And I know he's done some work in that area. And we have actually some documents on our cardio.org website about air, the effects of air pollution on cardiovascular risk. I know that the city of Cleveland was doing some work around monitoring this. And I know we have someone Ong in our group who is focused on sort of some of those issues and studying that. So I can't speak to all the details there, but that's an interesting, it's an interesting comment, and it's definitely a contributor. And we know that air pollution tends to be worse in areas that have poverty for a variety of reasons. So thank you for bringing that up. Yeah.
And the other thing I was going to mention quickly that I think we may have talked about before. So we have a little bit of extra data from Central, Kinsman, and Buckeye. It related to community health needs assessment on a neighborhood level. So maybe we can send some of that your way if you haven't seen it. It's from about 2 years ago now, but
yeah. Yeah, no, that's great, Tim. We use that in our co-design work. So we do actually have those. We have several health needs assessments, and that was one of them. But yeah, it's good to bring that up, that we want to use our community health needs assessments that are done both locally and in the region. There's different ones that exist, and we did try and look at all of those as we did our co-design work together. So thank you for bringing that up. And I think it is important that we look at things that have been created by our different regions in that area. So thank you. And Melody,
thank you.
Yeah, no, go ahead. Melody, you were asking a question. Have you been collaborating with the already existing community outreach nurses at UH? I think it would. So I love that you asked this question, Melody. We are in the process of actually trying to meet with each health system's community engagement groups. We did use some of their needs assessments and plans in our co-design work, and we have folks at each of the organizations, but I think we could be better tied to some of the community engagement pieces, and that's not just for our CTSC, which I think that would be great. And we have some ties with that, so I don't mean to say we don't have any, but I think it could be better. And so we actually have a plan to sort of do outreach to the outreach folks to really get a better collaboration and in that space. So thank you for bringing that out. And if you have a contact, Melody, that you think we should connect with, just to make sure we're getting the right people, then yeah, put it in or email me. That would be fantastic. And Jerry, I don't know if you want to unmute or if you want me to say it, kind of goes along with your response, but the best practices in your first case with hypertension work, even without insurance. How do we get buy-in and long-term usage from our healthcare systems for these fairly easy interventions? I laugh because it seems easier than it really is when you're actually doing the work. But yeah, I think that we did work with all of our healthcare systems to do this. And I don't think it was that difficult to sell because again, everybody wants to improve care for their patients. Some of the things we're working on now with our grant is how do we, really target to get better care for those that aren't responding to like system-wide and system level initiatives. And so I think hospital systems are used to doing really strong system level initiatives. And then they do like sort of focused effort, but can we be coordinated around that to do that focused effort together to have a greater impact? So, and then learn from one another. So I think I think I don't know, Jerry, if you have some suggestions or additional comments in that space. I think it's always a challenge to get everybody's priorities aligned and working in the same direction. So I think it's a constant thing to keep on our radar of work to do.
I think Cleveland in particular is pretty difficult to get these competing giant corporation-like systems to work together. I think, that's a real challenge. I mean, other CTSCs are amazed that that our partners, aren't necessarily in the academic community, but are these hospitals. And it's really hard because it's, they're competing businesses, really.
Yeah, I mean, that's absolutely true. People compete on execution a lot, and then they don't want to share business, it could be considered business intelligence, right? If you're doing something that's really improving health, you want to share it with another. So there is some of that tension. I think one of the ways we've dealt with that is really dealing with folks that are leaders around, quality improvement within their organizations, as opposed to maybe other areas where people might feel a little more competitive. And I think also grant funding helps bring that together, whether it's through Medicaid or CDC or I think there is some like, okay, there's some funding behind this, so we're going to collaborate as opposed to, some of the competition. But that's a good point. And it does come up where sometimes things don't align in effort. So I think that's a great point. Yeah, mentioning the working with AAPI populations to improve cardiovascular health equity on a pilot grant, hoping to collaborate. Yeah, that would be wonderful to connect. We actually met recently with Asia Inc. Around different AAPI populations and priorities. And it's interesting, like their feeling was that they actually had other priorities than cardiovascular health at the current time. So yeah, I'd be interested to hear more about what you might be doing. And again, that was one point in time, and I think related to how well they were doing with some of those outcomes compared to other health, health areas that they wanted to focus on. Other comments, questions? Nobody wrote in what they were going to do themselves in collaboration, except maybe I don't know YW how you say your first name, but besides you, I guess your pilot grant is a little bit, right? It sounds like, but I think that's okay. Maybe you guys can think about that in your head. Tim, do you think there are more positive demons to find and learn from? I wonder what the older folks in the deep red neighborhoods are doing if they don't have hypertension. Yeah, I think that, I do think that there are, because first of all, I think community-based organizations, health systems, and people often innovate to address their own health. And so how do we learn from those practices over time? And so we continue to see that. So I think that there are ripe opportunities for that in future work that we're doing. And I don't know if there's any last comments. I know, Mackenzie, you have some like a final slide that you want, I think. final slide or two, so maybe I should go to that, but feel free to put other things in the chat if something is popping up for you all. Mackenzie, I turn it
Yes.
over to you.
I will just quickly go over on this last slide, but thank you so much, Dr. Bolen. This was a really great presentation. So the middle QR code actually is linked to a red cap that will just allow you to provide feedback. And if you have ideas for future science cafes, you can suggest them there. And then next month on December 12th at noon, we actually will have Dr. Anita Misra-Hebert, and she will talk about dissemination and implementation. So that's the QR code on the left to register. And the last QR code on the right is just if you're not currently a member of the CTSC and you want to stay up to date with all the events and upcoming programs and things we have ongoing, you can sign up there. And I see that YW said that he will contact you about collaboration.
Sounds good. I can put my email in case that was helpful. If I didn't have that on my slides. So, all right. Well, thank you all for joining and sharing some of your thoughts and comments, and look forward to future connections. Thank you all.